I just wanted to start off the PowerPoint by doing a little bit of a review, as this slide should be a review of the respiratory system. So we know when we look at the lungs contain 5 lobes. The right lung has 3 lobes, an upper lobe, a middle lobe, and a lower lobe, where the left side just contains an upper and lower lobe, so only has 2 lobes. The lungs are lined with a serous membrane called pleural, and this pleura acts as a lubricant that helps to protect and cushion the lungs. Whenever caring for a client with an acute respiratory disorder, it is extremely important to do both a complete health history and physical assessment. When taking a patient history, we would want to ask questions such as, where have you been? Who have you been in contact with? How long has the symptoms been occurring? As far as current medical problems, this is where we would want to find out if they have any asthma, a history of COPD, what their occupation may be, do they have any allergies, are they a current smoker, or did they smoke in the past? As far as a physical assessment, we would want to do a good inspection of the lungs, both anteriorly and posteriorly. We'd be looking for things such as, is the chest symmetric? Does the client have a normal breathing pattern that is equal and regular? We would want to auscultate the lungs, preferably posterior if we can, comparing both the left and right side and working systematically down the lung field. If you need to, make sure you go back and review some of your breath sounds, right? Some of those adventitious lung sounds that we might hear and what they could indicate, like wheezes, rhonchi, crackles, things like that. A psychosocial assessment, this would look for any stress in the client's life, any recent travel, who they may live with. Do they currently live with somebody who smokes? Maybe the client themselves does not smoke, but do they live with someone? Does their spouse smoke? Our diagnostic assessments are things such as chest x-rays, CAT scans, pulmonary function tests, ABGs, collecting sputum samples, and very basically just checking our O2 sat. Another more in-depth invasive procedure might be a bronchoscopy. This is where the physician would go down the back of the throat and take a look into the lungs, both the right and left lung, to get a closer visualization. This slide should also be a review, and it kind of is just a refresher on some of the changes associated with an aging individual. As an individual starts to age, we start to see a gradual decline in their respiratory function, and this is due to both structural and functional changes. One of the big things we'll see is a decrease in the muscle strength. This decrease in strength also decreases the cough reflex and the ability of the lungs to fully expand, putting the individual at risk for things such as atelectasis or respiratory infections. What ends up happening when somebody has atelectasis is they have collapsed alveoli in their lung fields. These collapsed alveoli leads to a reduction in alveolar ventilation. Probably the most common type of atelectasis is acute atelectasis. And this occurs most commonly after any type of surgical procedure, or if the patient is post-op, or if the client is immobilized for any reason, and they have a shallow breathing pattern. We can also see atelectasis due to an obstructive reason. This could be due to a tumor in the airway, or any increase in secretions that are getting trapped in the airway. We can also see atelectasis in patients who have chronic airway obstruction that blocks the flow of air into a certain area of the lung. We can also see atelectasis in patients who have an increased pressure on the lung tissue. For example, if they have pleural effusions or a pneumothorax. The signs and symptoms that we'll see with somebody with atelectasis really depend on the amount of alveoli that are affected or have collapsed. If a large area of the lung tissue is affected, the client will most often complain of an increased respiratory distress. We will see both an increase in their heart rate and respiratory rate. They may complain of some pain. And we may see a decrease in their O2 levels. Atelectasis is diagnosed by completing a chest X-ray. And when completing a pulmonary assessment on a patient with atelectasis, we would expect to find diminished lung sounds in the area that is affected. When we look at ways for preventing atelectasis, it really stems back to those basic nursing interventions that we learned early on in nursing school. The main goal of these nursing interventions is to expand the lungs and to manage the secretions. So we'd want to encourage things like increasing mobility, frequent turning and repositioning, educating our clients on coughing and deep breathing and using their incentive spirometer. If the atelectasis is due to an increase in secretions, we would want to complete interventions to help mobilize those secretions, like chest percussion or postural drainage. If the atelectasis is due to a pleural effusion, the client may undergo a thoracentesis. Many institutions have incorporated the iCough program as a standardized way to prevent atelectasis. Pneumonia is caused by things such as bacteria or a virus that enter the lung field and cause inflammation within the lung tissue. Pneumonia can be broken up into subcategories, really depending on how the pneumonia occurred. Community-acquired pneumonia is just as it sounds. This is a pneumonia that the client contracted while being out in the community setting. Healthcare-associated pneumonia is when the client comes into contact with a healthcare worker. For example, maybe they went and had blood work done as an outpatient. Maybe they went to an outpatient chemotherapy. Hospital-acquired pneumonia is a pneumonia that is acquired while the client is hospitalized. Most of the times we see this in a post-op patient. Ventilator-associated pneumonia is when the client develops pneumonia while being ventilated. And what's really important to know is that both with hospital-acquired and ventilator-associated pneumonia, these pneumonias increase the hospital length of stay for the client. For someone who is on a ventilator, there are many interventions that are put into place to help prevent these ventilator-associated pneumonias. Things such as keeping the head of bed elevated at least 30 degrees, having the client be on a PPI to prevent any aspiration, providing oral care every 2 hours. An aspiration pneumonia can occur either in the community or the hospital setting. And this occurs when substances other than bacteria are aspirated into the lungs. So maybe the client had vomited is a very common instance in when we will see aspiration pneumonia. The clinical manifestations seen with a client with pneumonia really depend on the type of pneumonia and also if the client has any other underlying conditions, especially those of any respiratory illness. Although every client presents a little bit differently, some of the common clinical manifestations that we'll see will be things such as a fever, pleuritic pain. The client may have a cough with or without sputum production. They will be short of breath, tachypnea, and an overall feeling of fatigue. When we look at diagnosing somebody with pneumonia, this is completed by doing a complete history and physical on the client. They will undergo a chest x-ray, and if they are having a cough with a sputum production, the sputum would be monitored for a culture and sensitivity as well. In severe cases, the client may undergo a bronchoscopy. This would be completed in a vented patient or a client who is unable to cough up any secretions on their own. As far as preventative measures, we want to encourage our clients to be up to date on all their vaccinations, in particularly their influenza and their pneumococcal vaccine. In the hospital setting, we want to prevent pneumonia by increasing mobility, keeping the head of bed elevated, encouraging fluids, and doing our respiratory interventions such as coughing and deep breathing and our incentive spirometry to prevent any atelectasis. Medical management really depends on the type of pneumonia, which looks particularly at the microorganism involved. Knowing the microorganism helps to determine the appropriate antibiotic that needs to be administered. Antibiotics may be either PO or IV, depending on the client's situation. We want to encourage hydration because, as we know, both tachypnea and fever leads to an increase in fluid loss, so we would want to encourage hydration for the client. If any hypoxemia develops, the client may need oxygen therapy. Antipyretics or antitussive medications may also be used if the client is having any fevers or any harsh cough. A pleural effusion is a collection of fluid in the pleural space. Now, it is normal for an individual to have a small amount of fluid in the pleural space, as this acts as a lubricant. However, when somebody has a pleural effusion, there is a mass increase in the amount of fluid within that area. The client oftentimes presents with things such as chest pain, a dry cough. They may complain of feeling short of breath, especially when they are laying flat. Pleural effusions are caused by things such as heart failure, if the client has any kidney or liver disease, cancer, pneumonia, or sometimes we see this if the client has undergone any cardiac surgery. A pleural effusion is detected on a chest x-ray. Most often, the client will undergo a thoracentesis. And after the thoracentesis is completed, the fluid that was withdrawn will be sent to the lab to be analyzed. If the pleural effusion is severe enough, the client may need a chest tube placed to help continuously drain any more fluid. A pulmonary embolism, also referred to as a PE, is an obstruction of the pulmonary artery or one of its branches by a thrombus. Most commonly, a PE is due to a blood clot or thrombus, as I mentioned. You can also see situations where the obstruction is due to an air emboli or a fat emboli. This is why it's extremely important to make sure before administering any IV medications, we talk about the importance of making sure all the air is withdrawn from the syringe. The symptoms of a pulmonary embolism really depend on both the size of the thrombus and the area of the pulmonary artery that is occluded. Dyspnea or shortness of breath is the most frequent symptom that we see in these clients. They may also complain of sudden chest pain, We may also see changes in their vital signs, like an increase in both their heart rate and respiratory rate. The client may complain of feeling very anxious. They may also have some hemoptysis or diaphoresis. The most common used method for diagnosing a PE is the use of a VQ scan. With the use of IV contrast, a VQ scan helps to evaluate different regions of the lung. Depending on the healthcare facility, a CT angiography may also be used. A CT scan helps to provide a more accurate visualization of the PE. A D-dimer is a nonspecific blood test that would be elevated if the client was positive for a blood clot. However, this does not tell us where the thrombus is located. A D-dimer could be elevated in a DVT or a PE. As a nurse, when we are planning our care for any client in the hospital setting, we want to avoid that venous stasis, which would greatly increase the client's risk of developing any type of blood clot. So we would want to encourage ambulation. We would use anti-embolism stockings. So these could either be our sequential pumps or our TED stockings. If the client is unable to get out of bed, we can also encourage either active or passive range of motion. In clients diagnosed with a pulmonary embolism, anticoagulation therapy is suggested to be started immediately to prevent a reoccurrence or an extension of that thrombus. Depending on the client's condition, they may be started on either sub-Q Lovenox or heparin or intravenous heparin. Depending on the severity and cause of the PE, the client may also require long-term treatment with anticoagulants. There are many different types of oral anticoagulants that the client may have to take long-term at home. And these would be determined by the physician which medication they would be going home with, but it could include things like apixaban or Eliquis or warfarin, which other name is Coumadin. Thrombolytic therapy or tissue plasminogen activator is used to treat large pulmonary embolisms, particularly in clients who are severely compromised. Thrombolytic therapy helps to dissolve that thrombus quickly and then restores normal hemodynamic functioning of the pulmonary circulation. Before undergoing thrombolytic therapy, it is very important to determine if the client is considered a high risk for bleeding or if they have had any type of stroke in the past 2 months. Blood work should also be checked prior, things such as an INR, an H&H, and platelet count should be evaluated. Although rarely seen, a client may undergo a surgical embolectomy if, for whatever reason, they are not a candidate for the thrombolytic therapy. As a nurse, a lot of our focus, as I mentioned before, is on the prevention of the pulmonary embolism. So incorporating those interventions in our daily plan of care, also educating the client on the importance of the TED stockings and early ambulation. If the client underwent any thrombolytic therapy or if they were even started on anticoagulants, as a nurse, we are frequently assessing these patients, looking for any signs and symptoms of any active bleeding. Depending on the size of the thrombus, the client may need oxygen therapy to prevent any hypoxemia. We may need to medicate them for any pleuritic pain or anxiety they may have. And we also want to educate the client, especially if they're going to be going home on any long-term treatment with anticoagulants, about the medication that they are going to be going home on. Some medications, especially that of warfarin, requires frequent lab tests to monitor and adjust the dosage. Pulmonary tuberculosis occurs when an individual comes in contact and particularly inhales the bacteria of Mycobacterium tuberculosis, or TB. The bacteria is transmitted through the airways, as I mentioned, and once it is inhaled, it goes into the alveoli where the agent begins to multiply. Risk factors associated with tuberculosis would be visiting underdeveloped countries, if an individual becomes exposed to somebody who is positive, or if the client is immunocompromised. The tuberculin skin test, or PPD, is really just a screening tool to see if you've ever been exposed to TB. Between 48 and 72 hours after the tuberculin skin test has been administered, the individual should be reassessed to look for the size of that induration, or that raised area on the skin. A size of 0 to 4 millimeters is considered non-significant. If it is greater than 5 in the immunocompromised client, it is defined as a positive test. For an individual who is not immunocompromised and considered healthy, they would need an induration or a raised area greater than 10 millimeters to be considered positive. As I mentioned, a positive test indicates that the individual was exposed to TB. It does not necessarily mean that the disease is active presently in the body. It just means that there has been a past exposure. If you do have a positive test, you would then undergo things such as a chest x-ray to look for any visible signs of the active disease. A sputum culture can also be used for screening and diagnosing TB. This slide represents some of the common clinical manifestations that we will see with somebody who has active pulmonary tuberculosis. Oftentimes, the client will complain of fevers and night sweats. They will have significant weight loss. The cough may be either productive or non-productive, but if they do have a productive cough, oftentimes they might state that they've had some blood-tinged sputum or hemoptysis. Medical management of tuberculosis usually lasts anywhere from 6 to 12 months. And the reason for this prolonged treatment duration is to ensure that the microorganism is completely destroyed within the body, and also to prevent any relapse. A combination of multiple anti-tuberculosis agents are used in the medical management. Your textbook provides a nice chart of some of the commonly used agents for a client with active pulmonary tuberculosis. Some of the common agents used are INH and rifampin. Unfortunately, the medications used to treat TB can be very harsh on the client's liver. So the client will undergo frequent liver functioning tests, blood work tests to monitor their liver function. As far as nursing management, we want to promote airway clearance by things such as increasing hydration and educating the client on proper positioning to facilitate airway drainage. A lot of client education also goes into caring for a client with TB. The nurse should educate the client on the proper times to take their medication. Most of the medications are suggested to take in the morning or 1 hour before eating because food can interfere with the medication absorption. The nurse would also want to educate the client to avoid any alcohol. And as I mentioned before, to educate the client on the importance of following up with their liver function tests that would be performed frequently throughout their treatment plan. They may also have their kidney functions checked as well, so a BUN and creatinine may also be ordered. Sputum cultures are also monitored to evaluate the effectiveness of the treatment regimen. We want to encourage adequate nutrition by encouraging small, frequent meals and ensuring the client also is well hydrated. This can sometimes be tricky because the client often complains of anorexia and has an unwillingness to eat. In the hospital setting, if a client is diagnosed with TB, they are put on airborne precautions and placed in a negative pressure room. Anytime a healthcare worker enters that room to care for the client, they should be wearing a fitted N95 mask. To help prevent the transmission of the infection in the outpatient setting, we want to educate the client on proper hygiene techniques, including things such as oral care, covering the mouth and nose when coughing and sneezing, and proper hand hygiene.